Dear colleagues, hello again. We are at this new episode of Road to Venice, in which I interview members of the faculty of the next Venice. But this time will be not just a member of the next Venice. She's part of the executive board, and it's an incredible honor to host today Prof. Erika Mendoza. Hello.
Hello, hi. It's an honor to be with you. Saluti a tutti.
Thank you so much. Thank you so much. As usually, I will start by telling short information about your bio. Probably it's not necessary because all of the colleagues perfectly know you, but I will do for the audience and for the show. So you are among the most important expert and opinion leader on duplex ultrasound, and of course also on the CHIVA treatment. And about these topics, you authored a lot of books, which I suggest everyone to read. And also during the years, you've been involved in scientific research and of course in a lot of scientific meetings. You have been since 2015 General Secretary of German Society of Phlebology. In 2022, you have been President of German Phlebology and Lymphology Society meeting. And in 2023, President of the European Venous Forum meeting, which I attended, and it was a great meeting. And since 2000, you have been President of German Society of CHIVA, and since 2023, member of Educational Committee of WIP. Probably I forgot something, but first of all, congratulations.
Thank you.
And also, I would say that you speak a lot of language. You speak German perfectly, of course, Spanish perfectly, Italian perfectly. So I was thinking, let's do it in Italian because it's easier for me, but not probably for the audience. So we will conduct this interview in English.
Thank you.
So I would touch some topics today with you. There are ultrasound, lipedema, lymphedema, and CHIVA, of course. And I would start with ultrasound because there is no better person to ask this question. And for you, what is the importance of a correct diagnosis in the venous disease and how should be performed?
Thank you for the very important question and for the introduction. Yes, ultrasound is the queen or the gold standard for the diagnostics of venous disease, and it is of course important to make one investigation to be sure that the symptoms the patient has come from the veins, because there are so many symptoms like that could mimic veins, and then it's deep veins, it's superficial veins, and I always repeat, and a little bit of advertisement. I've just finished a book with Minerva Medica, basic phlebology for the starters and newcomers, and there my most important message could summarize to say, it is not the ultrasound that defines the treatment, but it is the clinic that defines the treatment. But the moment you see a person with veins and the person is upset with the veins, it is important to do an ultrasound to establish if the veins are responsible. And this should comprise deep veins, saphenous veins, tributaries, and have a look at the combination of clinics and tissue and how is this all combined. And the only proper way in my eyes to do this is with ultrasound, no other, and duplex ultrasound, no longer CV Doppler or something like that. Of course, if you live in a region where you don't have other possibilities, but Europe is not that case. And the second important thing is you should learn it, because if you do know how to investigate deep veins, you do not know how to investigate superficial veins. It's like, I mean, I've written a book of 250 pages only on superficial leg veins. There's so many interesting things to learn. And our old professors didn't do ultrasound, and I think we are changing now. You are a wonderful leader of a new wonderful vein in Venice, and you are perfectly able to do ultrasound, and our generation is able and should be very aware that this is a very important instrument. And it is, I mean, I learned it, you can.
Well, it's not that easy, as you said, but if you study on your book, especially you can understand better, of course, pattern or reflux, for example, from, the junction, that I think it's really important to understand now why we had so many recurrency, for example, after stripping or other treatment in which we didn't investigate as well, pelvic reflux or other things like that. So please, everyone that will start doing phlebology and treating patient, do a correct diagnosis with ultrasound. And if you don't know how to do it, please read Erika's books, please.
Okay.
And then I would like now to talk about a little bit of lipedema. This is a medical condition that we are understanding now a little bit better than in the past. Also, patients now receive a correct diagnosis and they can learn something also about their condition, sometimes in internet, which is sometimes not that good. But anyway, of course, from phlebologists, vascular surgeon, general surgeon, they now understand what we talk about. And you are among the most important experts also in this field. You have been involved in the guidelines, German guidelines for this condition. And of course, I read your guidelines, and I totally agree, of course, with you about the importance of compression therapy in the management of the pain, and also in the reduction of the inflammation that with lipedema you can have. And my question would be, do you have an advice in which type of compression we should prescribe?
Yes, it's a difficult question because also depends on the place where you live and the availability of things and the cost of the things. I'm very happy that this German guideline, I mean, it is the effort of Gabriele, who made a real good job, and the International Lymphedema Association, where also a lot of people is in, and they have this paper also written and published years ago. These new concepts have been really flooding lots of parts of the world, and the comprehension of the lipedema is wonderful. I'm very happy about that. We are still trying to change the name, but this is like a little bit more difficult. But the compression, of course, if the patient has obesity, a part of lipedema, and the leg is like with furrows and so on, the best thing to do is either use flat knitted compression, sometimes in 2 or 3 parts, like a capri, yes, I don't know how to say.
Yeah.
Yes, and stockings, so they can combine, or leggings for the summer, so that they don't have to wear shoes. In some cases, the medical adaptive compression devices also can help, just to reduce pain on a certain region. But in slim patients with lipedema, my experience is that often round knitted stockings also help, and they don't look as ill. I mean, if you wear this flat knitted, you look very ill, even though there are wonderful colors and so on. But sometimes the first approach to the patient is offering him like a not so huge stocking, just that they observe that the compression alleviates the pain. And I don't know what you pay in other countries, but in Germany, a leggings in flat knitted will cost the patient, in Germany it is paid by the public healthcare systems, but the cost is among 800 euros. And if I think that somebody has to pay this on his own, I think a regular compression, around knitted compression by 100 euros is more accessible. So this depends a little bit on the possibilities, and you have to put the compression on the place of the body where the pain is most. And as you don't have an edema, you can get away from this principle. You have to start at the foot. If they have only thigh edema, thigh lipedema, thigh pain, they can just use a Capri size, and this will be more comfortable for them.
Yeah, I think it's really important to stress this concept with the patient, because sometimes they refer to us, they read something on internet, they Googled, and they come here and say, okay, I'm ready. Why don't you prescribe me a liposuction, for example?
Yeah.
So I said, probably it's the last part of the treatment. And I think that's the other question. When we should advise and when we should not advise for a liposuction, for example.
This is such a difficult question. And in Germany, we have stopped now, fortunately, because there was a time where the healthcare minister, I don't know if his sister had lipedema, he was very, very engaged in having liposuction reimbursed regularly for lipedema patients. And in 1 year, this was like the current status of the art. And lots of ladies unhappy with her body shape were liposuctioned, but these were not lipedema patients. And we have to differentiate two things. Are we treating a lipedema patient or a person unhappy with her body shape? That person unhappy with her body shape on her own pocket can pay what she wants, yes? The lipedema patient, then you have to differentiate, and this is what we did in Germany, and we had a little bit of struggle with the law, but the German Society of Phlebology, I was there in Berlin, and so, because we said it is no use to make a liposuction to reduce the lipedema pain in persons with a body mass index higher than 35, because they have first to reduce the weight. And then if there is still a lipedema with pain, very, very often if you reduce the weight, for example, with bariatric surgery, if it's sometimes they have the BMI of 50, then you do a bariatric surgery and then you can consider doing other things, which not obviously has to be a liposuction. It can be, I don't know how the name is, to correct there is so much skin left and they have to make this skin correction. And often the pain, and this is studied and published also in our guideline, if you reduce the weight, the pain will reduce. The other thing is if a person claims for liposuction and doesn't wear compression, it's like if you don't wear compression, you don't have a lipedema. So first wear your compression, and this was the rules in Germany. We made a study because there is no evidence that lipedema has a real good impact on the long view for liposuction. And the German government then reimbursed a study which is still ongoing and made the criteria you can access to liposuction if you had already a half a year of compression and try to reduce your weight with dietary things and complemented quality of life and so on. And if this didn't increase your situation, then you could have this liposuction in a study setting. And we are waiting for the results now.
Yeah, I think it's really important let people understand, patient understand that there is of course, the diagnosis at the beginning of this process, but there are a lot of things to do: stockings, skincare, diet. There are a lot of works about the type of diet, keto or not, and sometimes it could be necessary also to give a support for lymphedema that sometimes is present also, and so. It's important.
Obesity-related lymphedema. They have lipedema and obesity-related lymphedema, and of course, then you have to treat the lymphedema also. Yes.
Exactly, and so I always say to the patient, okay, liposuction is a possibility, but we will not start with this point.
No,
so
and it will not heal.
Yeah.
If the person goes on eating carbohydrates, the remaining fat cells will increase again. This is not the solution.
Totally agree. And so we mentioned lymphedema, so I would like now to talk about that. Of course, you are an expert and opinion leader on this.
No, I have to explain this. I sometimes do studies like this study I think you will comment on, when I am fed up with something. And then I say, I have to demonstrate that people is doing stupid things. And this was in Germany, the reimbursement of the lymphatic, this compression devices is not given. You have to struggle, and it is much easier for the patient than going to live. And I wanted to demonstrate, but sorry, I cut your question off.
No, but it's really important because these type of patients are patients that suffer from a chronic disease. So it's important to treat well the patient in the acute phase, in the early stage, but of course give the instruction and the possibility to have a long-term therapy. And about that, you did an incredible job with I read your work about the treatment of this patient in the chronic phase, not in the acute phase, with using intermittent pneumatic compression, EPC. And what surprised me, and it's incredible because you demonstrate with the cost that you put on the work that patient could have, of course, the results that we are looking for. So pain relief, reduction of edema, and everything that we look for from the health point of view. But they can save from 55 to 85% after 10 years cost.
Yes.
So could you explain to the audience better this work?
Yes, I had a lot of patients in the chronic, in the stable phase of the lymphedema treatment, and I selected those that didn't change their body weight in the last year, and that didn't change we measure the circumference of the leg every 3 or 4 months, and where this was stable, more or less 1 centimeter, but not more changes, we asked them if they wanted to participate. And they were already on a treatment with flat knitted or round knitted, depending on the situation, compression. They had a lymphedema, and they had pneumatic lymphatic drainage 1 or 2 or 3 times a week, depending on the situation. And we had, I don't remember how many, I think 24 patients included, and they had 3 phases to go through. They had to come from this treatment phase. The compression was worn all the time. And then we started either with lymphatic drainage plus IPC. Then we had 2 weeks, 4 weeks, 4 weeks this block, 4 weeks again, as always, only compression and manual lymphatic drainage. And then the other 2 weeks again, either IPC alone or IPC and lymphatic. And this was randomized just in case the order of the application could be result somehow relevant. And the interesting thing was that there was no change in volume. We have a manual measuring, but also we have a volumetric measuring with the Bodytronic from Bauerfeind that is there in my office for study purposes. I'm so thankful for that. And Bösel was the device, and they was also very, very engaged. They went to the house of the patients, introduced them to the use. They collected the device to avoid that they use it in the phase where there was no IPC supposed to be. And we had really no differences at all. I mean, we have one significant difference, but it was 0.2 centimeters circumference change when you used both than when you used only one. But this is like nothing. And the quality of life was really stable also. So we could conclude that in at least for 4 weeks, the result was the same if you use IPC alone or MLD alone. And it was not really better if you use both. And my conclusion would not be to say, okay, the patients can have the device and forget about the physical therapy, because they tend to forget about. I mean, often people, especially with lymphedema, or lymphedema mixed with venous diseases, they are more prone to forget about their feet. And then suddenly there is an ulceration. So I would propose to reduce the lymphatic drainage to once a month, just to have somebody having a look, and the rest of the time the device at home. This should be a better system. And in Germany, at least, we have so many obesity-related lymphedemas today that the physiotherapists cannot cope to have the patients in there to attend them. And this is a real problem.
Yeah, it is. It is. I can say that in Italy, probably it's more a problem for the patient, because we don't have a lot of hospital or public cover about this topic.
Yes.
So I think that give the patient an opportunity to be under good therapy and save some money. I think it's a great plus, and they will be happy to hear. So let's move to the last topic. No, not the last, but almost.
Yes.
And we will talk about CHIVA. You are among the most expert on CHIVA, and of course you do CHIVA. You say it probably from 2000 or something like that.
No, I started 96.
Okay, so a lot of years of
Yes.
experience.
I learned it in Spain, and then we moved to Germany, and since 97 we do it in Germany.
Okay, so a lot of experience to share. And, there is always a great debate about, this topic. And sometimes now, when we talk about that, it's like a team against another team. But sometimes we forget that we can understand Shiva if we think about hemodynamics. And also, we can try to understand to perform Shiva also with less invasive way than open surgery. So I was thinking about laser crusectomy, for example, and spare, the GSV, or close the escaping point or refluxing point for a perforator, for example, also with the laser or with the glue sometimes if you use glue. And we were talking when we were not on air about this, and you said, yes, I do a technique that is called hot Shiva. Could you please
Yes.
tell me something about that?
I wanted to ask you how many hours I have to answer this question.
All the time that you want.
For the question with the teams, I've been thinking a lot of it. I started doing Chiva in 96, and then we moved to Germany in 97. My first husband, he died in 2000. He was vascular surgeon and was completely convinced that German people would, wow, say this is interesting and logic and so on. And there was a wall, a real wall. And this, in my analysis, is because in that time, surgery was a hospital thing and Chiva is an office-based thing. And lots of hospitals had their systems, their vascular surgery services financed with stripping. And so it was like a political problem if people suddenly weren't treated in the hospitals. The second problem is that in the opinion leader countries like America and England, the phlebologists do not do ultrasound. Still today, they have their technicians and they rely on the technicians. And then, sorry for that, I have lots of friends there, but they do like they know what this is, but they don't understand hemodynamics. And this is a big problem to solve. But also in Germany, where it starts that people always do their own ultrasound, it is so easy to destroy a vein because you see the varicose vein and you do it, and you don't have to think. You don't have to stop and think, and the thinking is not reimbursed. And the more the time goes, the medicine is all about reimbursement. I'm very sorry to say so. And this is, in my opinion, another point. But I always was depending on a surgeon to make Chiva because I'm not a surgeon. And this is when the laser therapy came up, and the venous, I have both, radiofrequency and laser in my office. I was so fed up by depending on surgeons and finding, I sometimes found them, but you have to say the surgeon, you have to do this. And surgeons, they don't like to have somebody telling them what they have to do. And I started in 2006. I bought my first bare fiber laser device and started doing those cases that were difficult, like very obese persons that were difficult for surgery. And I started with 10 centimeters, and now I am at 7 to 6 centimeters closure with heat. And this works really good. I position my fiber distal to the last, I allow the drainage of the tributaries of the groin to the deep vein. And this is what I claim. I say, if in all these studies we do comparing stripping to laser, we would register if the terminal valve is competent or not. I'm sure that in case of a competent terminal valve, laser ablation is better because you have a barrier to the deep vein. And in case of incompetent terminal valve, the frequency of accessory anterior refluxes after laser will be higher than after stripping. So we could perhaps have a choosing of what to do if we would look at this earlier. But I made this and I published, I think in 2013, a German work, but it is translated to English in the phlebology, in the German phlebology, comparing 100 persons with crosectomy and 100 persons with Chiva hot. And the results after 1 year were exactly the same in the VCSS, CRP evolution, diameter reduction. So there were no difference at all between both. And this is why as you said in your question, it is much more, if you do a little crossotomy, the scar is not as big, but at least it is a scar. And if you can do it endoluminal, you will destroy a little bit more of saphenous vein, but you will have less skin scar, of course. In perforating veins, it is very seldom that they are the refluxing point, and then it is very seldom that they are really straight, but I tried. I have to tell you that I did twice endoluminal closement. I did this CHIVA, the deep CHIVA. If you have a vein, a refluxing vein in the gastrocnemius muscle with an ulceration, and the vein were a little bit straightforward, and I tried to introduce the laser there. And it is difficult to make a tumescence in a muscle because it leaves, like it doesn't stay there. But and I didn't close the vein, but I reduced the diameter, and the ulceration closed. So it is open to do a lot of things with it. There is much of future. And the HIFU, which were presented last year in Venice, if HIFU comes really reimbursable, HIFU is the best option to do CHIVA.
Of course. Well, you know what? I think that sometimes people just think about a topic like, should be done in this way. But if we look at what we do in our clinical practice every day, sometimes we could understand that sometimes we're doing CHIVA, but we are not calling CHIVA. We're doing CHIVA with the laser or with another technique such as HIFU, as you said, or glue when you close just a point for a recurrency, and then you do the escaping point, and that's it. You're doing CHIVA. So sometimes it's the word that scares for the reimbursement.
I don't know why. I think it's a very good, fluffy word, but
yeah, I think that the reimbursement should be probably the point of the, CHIVA is not that good for some colleagues. But anyway, that's the reason why everyone should come to the next Vein in Venice and understand a little bit more about hemodynamics if they don't know, and about CHIVA, of course.
Of course, yes. I hope I will find the time. I have a German masterclass on ultrasound, and I'm trying to make an English one online. And then years ago, I did a CHIVA thing also in German, and I will try to make it, because people sometimes like more to see videos of people being investigated and so on. So I will do my best to increment the knowledge about hemodynamics.
Yeah, it's great. So thank you so much for giving me your time. But I have the last question, so please be patient for the last. This is the question that I ask to all the members of the faculty that I interview. And it is, what advice would you give to a young colleague that think to start, this job, become a phlebotomist and become, an expert on this? What you can advise him?
Oh, a lot. It's funny. I had the honor to be asked by Minerva Medica to write a book, and they wanted me to write a book on ultrasound. I said, no, I did it already, if I can choose a topic. And I were allowed to choose my topic, and I wanted to call it phlebology for dummies. But the topic for dummies is already used. So I called it basic phlebology, and just finished it last week, and Minerva is now doing it. And it is like, I'm really trying to give all my heart into this. If you treat patients with veins first, veins and edema is like the mirror of all the body. Don't forget that this is a person with hypertension and medication and so on, and other diseases that can influence the legs. So don't look at the legs, don't look at the vein. You have a person in front of you. This is the first advice. The second advice is, what would you recommend your mother or your father in this situation? And not treat just what you have learned, but treat for what is best for the patient. Marianne de Mezener made this wonderful article with patient-tailored therapy. We have lots of things, and if you don't do everything like me, I don't do surgery, but I have a wonderful surgeon with whom I work. So think what is the best for the patient, what is affordable, financial for the patient, and then think really if an intervention is needed. Because one thing we know when we treat the patients, in 10 years, 50% will have a recurrence. What we don't know is how long it takes from a visible vein to a chronic venous insufficiency. and it can take 10, 20 years. So go with the patient, walk with him a time, and look what the patient needs, what he wants. I always ask the patient, what can I do for you? And they say, you should know. No, yes, I think I know, but you should tell me what I can do for you. What is your question? Because lots of them doesn't want to have a therapy. They want to know if it's necessary and which risks they have. And this is the point, I think. If we are not treating our pockets with the money, we are treating persons. And we should remember that.
Yeah, that's a great advice. Really great advice.
Thank you.
So I would be, of course, honored to stay with you a couple of hours and listen to your interview. That, you know, it's fantastic. Always fantastic to hear from you. But I would leave something for the next Ven in Venice. Otherwise, no one will come.
And I have to congratulate you. You are doing such a great job organizing everything and doing these interviews, and you are so engaged. I appreciate it.
Thank you so much. Thank you so much. When something comes from you, such as congrats, for me, it's double. So thank you so much. And yes. We will see each other in Venice
yes.
in 2 months. Yes. So thank you so much. And
looking forward.
Okay. See you soon.
Great time. Bye-bye.